So first, before I start, I want to give a huge thank you to three people who really helped make this Lunch and Learn possible. So Callie for always figuring out the logistics for Zoom and this event. Also Bergen helped me edit the PowerPoint and create some of the visuals. And then Hallie, who I've never met, but she really helped put together the the email infographic that went out to you guys, that beautiful kind of lunch and learn graphic. So major thank you to her for putting that together. So the focus of this presentation, I'm hoping to cover four kind of major key takeaways. The first being to just kind of discuss what HCV is, or hepatitis C, how it's transmitted, and what is the common course of the illness. Second, I'm hoping we can increase our familiarity with recent patterns in the hepatitis C epidemic, kind of locally and then on more national and global scales. Third, I'm hoping we can raise awareness around what we can do, what evidence-based strategies exist to combat the spread of hepatitis C, especially in rural environments. And then finally, my overarching dream is that we all can kind of leave a little bit more empowered to do something or take some action in order to reduce the effect that HCV has on our communities. So first, we're going to discuss a little bit about what hepatitis C is. And I'll just make a language note that I'm going to use the full name hepatitis C and HCV interchangeably throughout the presentation. So this is a lovely graphic by the CDC, and they point out that there are three major causes of viral hepatitis that people in the US should be aware of. And so hepatitis, the term hepatitis refers to inflammation of the liver, and viral hepatitis refers to a range of viruses that can cause inflammation of the liver. They cause other things as well, but inflammation of the liver is one of the hallmark symptoms. And so there's hepatitis A, and that is usually spread through, it's like water and contaminated food. Not that big of a problem in the United States, especially because there's a vaccine for it. Hepatitis B can also be spread through blood transmission, but there's a vaccine for it. So even though its transmission is similar to hepatitis C, because we have a vaccine, it is less of a problem. And then hepatitis C is kind of the big problem in the United States, especially right now. There are treatments available for it. There is no vaccine. So it can spread quite rapidly, especially through blood-to-blood transmission. There are other forms of hepatitis. There's hepatitis D, hepatitis E. They're not very common, so we don't really concern ourselves with them that much. Also, an important language note is that there are a lot of viruses that kind of start with an H, have a middle letter, and then end in a V, right? So H, A through E, V, HIV, HPV. So it's just important if you're talking to people about HCV, hepatitis C, that you kind of take a moment to make sure that you're talking about the same thing, because it can get super confusing. So we're going to be focusing on hepatitis C. So hepatitis C is a systematic disease, which means it can affect all or many organ systems. It primarily affects the liver, but outside of the liver, it can also damage the kidneys, the pancreas, leading to insulin resistance, and many other organs. And there's actually an increasing understanding of these, I think they call it like extrahepatic symptoms, so symptoms outside of the liver that are increasingly causing some scientists to worry. An important note about hepatitis C is that not everybody who is exposed to the virus develops kind of the chronic or long-term infection. So between 25 to 34% of people who are exposed to the virus are able to clear it themselves, maybe with symptoms, maybe without symptoms. And that's important to note because when somebody gets screened for those, for hepatitis C, about 25 to 34% of people may show that they are HCV reactive or they have antibodies to HCV, but they don't currently have it. So that's important. That's one of the reasons why follow-up testing is super important to ensure that the person has or does not have hepatitis C. And then one of the main reasons we're concerned about hepatitis C is that people who do develop this chronic or long-term infection with hepatitis C, After about 20 to 30 years, there becomes an increasingly high chance that that person will develop liver cirrhosis. And so the word cirrhosis kind of means scarring. Fibrosis isn't scarring, but it's usually like earlier stage scarring. And that can make it really hard for the liver to do its job and function, which can cause severe illness later on. And once kind of liver damage is happening, that also leads the way to cancers forming, and those can be highly fatal conditions. So who should be concerned about hepatitis C, or at least consider getting testing? The CDC recommends that everyone age 18 or older be screened at least once for hepatitis C. Populations who should especially consider getting testing are listed kind of on that left graphic. And so those are people who are pregnant. That's because it can spread to the child during pregnancy and birth. People who inject drugs regularly should get tested regularly. And then people who have injected drugs even once should strongly consider being tested for hepatitis C. And that is because injection drug use is one of the most common risk factors for the transmission of hepatitis C. Other groups of people who might want to consider getting hepatitis C test are those with HIV, and that's because HIV and hepatitis C share many of the same transmission pathways. People who have abnormal liver tests, because hepatitis C can cause inflammation of the liver, and so abnormal liver tests might be an indicator that there's some form of inflammation that might be due to hepatitis C. And then these latter bullets on the visual on the left refer to medical procedures. And that's because, especially in the 1980s and 1990s, before there was a strong awareness of what hepatitis C was or how to prevent its transmission, we believe that there was a considerable amount of transmission that happened in medical contexts. And then on the right here, I have another note that says that any person who requests hepatitis C testing should receive it, regardless of whether they disclose risk behaviors or not. And that's because people might ask for testing, but might not want to say why they're requesting testing, because many of these, the reasons that somebody requests testing might be due to stigmatized conditions. And so why is testing so important? I think a major reason is because hepatitis C is so underdiagnosed. So this is a researcher, Cowdley, referencing another researcher here, but quote, according to a 2016 study, approximately 1 out of 2 people infected with HCV are unaware of their diagnosis, but the rates of undiagnosed HCV infection range from 45 to 85%. And so that's really concerning, just because one, if someone doesn't know that they have HCV, then that means that they might not know that they need to consider taking preventative measures to prevent its transmission to others. And then also, HCV can linger in the liver for life, and it's gradual. So it increases the amount of damage it does to the liver over time. So late detection of hepatitis C might mean that somebody only gets diagnosed with it when they're in the cirrhotic stage of their liver, so really late stage when there's already a lot of damage. We would probably prefer for them to come in when there's little to no liver damage, so we can monitor them or get them linked into treatment before that damage occurs. And I talked a little bit about the symptoms and transmission, and I wanted to spend some time talking about hepatitis C and kind of what effect that has on people's lived experience. So these are just some quotes that I'm pulling from it was a systematic review of the qualitative literature related to hepatitis C. And so this person living with HCV just talks about how it disrupted their daily life. So, quote, "You cannot fight it. It is not a tiredness that you can fight like a normal tiredness. A normal tiredness, you can fight it and get a second wind, or if you had a few cups of coffee, it would keep you going. None of this works with this tiredness," end quote. And I found that quote really powerful because it seems like in the medical community, there's a real emphasis on how hepatitis C affects the liver and liver damage. But from a patient's perspective, what they might not notice, that liver damage, especially early on, what they would notice could be chronic fatigue, or debilitating fatigue. And that's one of those things that I think can get overlooked, is just how much hepatitis C can interrupt quality of life and daily life, even if there's not severe liver damage. Then a second quote I want to share is related to stigma. And so, quote, "The doctor rang me at home at 11:30 p.m. and said, 'You've got Hep C. You're a junkie, aren't you?' I had never been a drug user. I had never met an intravenous drug user in my life. He said, 'You could have only gotten this if you were a junkie.' So I thought that was just stupid, and I dismissed the diagnosis." End quote. And I think this quote really highlights the amount of stigma that people can interact with when they are accessing the medical community with hepatitis C. And what I thought was also really interesting about this quote was it talks about how that stigma not only affects people who have stigmatized behaviors, but it also can reduce the quality of care for everyone. Because anybody can have hepatitis C, but because it is so often associated with injection drug use, which is a stigmatized behavior, that can decrease the quality of care for everyone. So now I would like to talk a little bit about the epidemiology of hepatitis C, kind of looking at trends and patterns in the hepatitis C epidemic on local and national scales. So on the global scale, in 2015, it was estimated that about 1% of the world's population was infected with hepatitis C. But we can kind of see in the map that I've included that there are drastic variations between countries in those hepatitis C rates, right? So hepatitis C is more common in sub-Saharan Africa and in Eastern Europe, but it is still considerably common in the United States. It is actually the most common bloodborne infection in the United States, and it is the leading cause of liver cirrhosis and liver cancer. And not only is hepatitis C common, it is also very deadly. So this graph on the left is showing how hepatitis C and the amount of death it's causing relates to all the other 60 notifiable infectious diseases monitored by the CDC from 2003 to 2013. And the concerning trend that the CDC noticed was that while all those other nationally infectious diseases and conditions, their infection rate or the amount of deaths they were causing was decreasing, hepatitis C was increasing. And that's related to a lot of things, including lack of access to treatment and the rise in injection drug use. But it's very concerning that we're seeing this rise in deaths. And then on the right, we can kind of see, even in more recent years, the amount of deaths per year that have been caused. And it varies from a low of a little over 16,000 deaths per year to a high of a little under 20,000 deaths per year. So it's a significant killer. And what's even worse is that it's not as though it's a killer that kills indiscriminately. Because of systematic differences in healthcare quality and just kind of healthcare and health in the United States, hepatitis C has also been cited as one of the drivers of the racial health gap, or the racial life expectancy gap. And here we can kind of see, so the CDC refers to one of the population groups as American Indian or Alaska Native, but indigenous people as well. We're seeing much higher per 100,000 population. Hepatitis C claims much more lives in the Native communities, in communities of Black Americans and Hispanic Americans compared to white Americans. And so that's a cause of the racial life expectancy gap. And I was reading some other research that was saying that this is actually, this life expectancy gap is getting worse as it relates to hepatitis C, because more effective but expensive treatments are coming to the market. And because of what some researchers refer to as discriminatory prescribing practices or healthcare access practices, marginalized communities are increasingly being shut out from these treatments while other groups are gaining access to them. And so besides the kind of racial differences we also see age differences, particularly an interesting bimodal distribution. So we see that HCV, new cases of hepatitis C or newly diagnosed cases are pretty high in the younger populations. And we usually attribute this to young people who are injecting drugs. currently injecting drugs. And then we also see in the older population, we see that there are higher rates. And so the older population, there's also, those might be late cases, late diagnosed cases that originated from injection drug use. But it might also be things like the transmissions that had happened due to kind of medical exposures. And so I've kind of touched on this before, but the amount of new hepatitis C, chronic hepatitis C cases is rising. It is not going in the direction that the CDC wants, and there's been an increasing kind of warning of, if these cases continue to arise, we're going to have problems now, but we're also going to have problems in 20 to 30 years when, if these cases are untreated, which many are, it's going to cause a lot of chronic liver disorders. And kind of very concerning for us in more rural environments is that the trend, the increase in new cases of HCV is more pronounced in rural regions than it is in urban regions. So this is just meaning that it's getting worse everywhere, but this kind of increase in new cases seems especially pronounced in non-urban regions. And so I've talked a lot about transmission and what can be done to prevent transmission or reduce the risk. So the National Harm Reduction Coalition has some amazing resources on their website about how people can reduce the risk of transmitting HCV or contracting HCV. And it really comes down to the biggest risk we know is from sharing needles that are used for injection drug use or sharing equipment, because HCV can live for a pretty long time in both of those. And so the best way is to use new and sterile equipment every time someone injects. However, it's really important to acknowledge that due to the lack of supplies, that is often due to laws that make it very difficult for people to access new and sterile syringes every time they inject, that might not fully be feasible for everyone. And so some people, you know, if you need to reuse a syringe, it's good to mark your own. So at least you're using your own syringe that has not been shared. And if you must share, to try to clean the syringe, especially with something like bleach, might be a way to reduce the risk of HCV transmission. Besides those related to injection drug use, it's also important to try to use new and sterile tattoo equipment because it can spread through tattoos if that's not a sterile environment, as well as some household interactions. This is much, much rarer, but sharing toothbrushes, nail clippers, and razors, basically anything that can get blood on it, and that blood could be transmitted to somebody else, as well as snorting straws and crack pipes, which might get some blood on them. And then sexual transmission, it seems that sexual transmission of HCV is much rarer, but it can occur. There especially seems to be an increasing amount of hepatitis C transmission through the sexual route among men who have sex with men. So that's definitely something, is to, whenever possible, use condoms and lubrication to kind of mitigate the risk of hepatitis C spread. So hepatitis C in Nebraska. There's some good news in that hepatitis C seems less common among Nebraska's adult population than the US population as a whole, right? So it's estimated that about 0.56% of Nebraska's adult population has been exposed to hepatitis C versus about 1% of the US population as a whole. So that is good. That suggests that prevalence is low. But we should caution against being too cautious because, as I was showing on some previous slides, it seems that in non-urban regions, we're seeing an increase in hepatitis C. And this graph kind of backs that up. So in panel B, the one on the left, we see that hepatitis C back in 2006, new cases were mostly concentrated in kind of the northeast of the United States. But then in panel C, the one on the right, we're seeing how hepatitis C is increasing everywhere, or in most places, but it's especially increasing in kind of, it seems like the hotspots are moving westward towards the Midwest and Appalachia. So then this section, now transitioning to talk a little bit more about treatment and prevention, but I kind of touched upon prevention in the last slide. So hepatitis C is treatable. It's been treatable for a while. So in 1998, the FDA approved pegylated interferon injections coupled with daily ribavirin. And it was a cure for hepatitis C, but it wasn't as effective as we would hope. It was only about 50% effective, and the treatment could take 24 to 48 weeks. So it was a long treatment course. And roughly 1/3 of participants dropped out of treatment due to side effects. And it can kind of make sense. A lot of people who were being treated didn't immediately see the harms of hepatitis C. It was more of a long-term condition. The cure rates were really low, and the side effects were apparently brutal. So pegylated interferon and that era of treatment wasn't the best, but it was what was available. Starting in 2011, there were direct-acting antivirals that started to hit the market, and these were much more effective. So they were about 90%, 90% of the time achieved what is called sustained virologic response, which is in lay terms very similar to a cure, like cured, basically cured. So about 90%, but oftentimes more than 95%. It was a shorter treatment, much fewer side effects, and it was effective across a wide variety of the HCV genotypes, whereas the earlier treatments, there were some genotypes that were much more resistant than others. Of course, the downside to this wonderful treatment is that when it came to the market, it kind of shook the public health financing world a little bit. Gilead, when they first marketed it, Harvoni, it was sold for a list price of over $94,000, which is over $1,000 per pill. And that generated a lot of controversy. A lot of public health people were like, how are people, private insurance is going to afford this? But more importantly, because hepatitis C is oftentimes concentrated in more marginalized populations, that meant that those costs would oftentimes be assumed by Medicaid. And Medicaid budgets are already oftentimes incredibly stressed. And there became this huge kind of concern about how are Medicaid budgets going to pay for this? And we'll explore some of the ways that they did manage these cost concerns that might have enhanced racial disparities, other disparities, and might not have been the most ethical ways to handle it, but that is an ongoing debate. And so this article is from Kaiser Health News, and they were talking about that was, back when it first came out, they were that huge price of $94,000. Now they're releasing generics that are much cheaper. So it seems like those concerns are being mitigated, but they definitely had a lasting effect on policy and how we think about hepatitis C financing. So yeah, this is another headline from Kaiser Health News talking about, there's a life-saving hepatitis C, but it doesn't matter if you can't afford it. And so some public health researchers have kind of looked at, well, how did Medicaid programs try to handle this? And they think, and there's some evidence that suggests that many limited access on the condition of alcohol or other drug use. So they said, if you use drugs, if you're currently using alcohol, you are either can't access treatment or on lower priority for accessing treatment. And these researchers found that did decrease the amount of money that the Medicaid programs were spending on hepatitis C. But was that a discriminatory practice? Was that based in what was medically relevant or medically best? That's very debatable. And there's been some research. There was a concern that people who are currently using drugs or people who are currently struggling with alcohol use, that they might not be able to adhere to treatment or might become reinfected with hepatitis C even after being treated. But there's been some studies that show that that's not as much of a concern as long as you couple the hepatitis C treatment with other treatments addressing kind of the root causes. Well, why did this person walk in here with hepatitis C? And if you kind of address some of those other concerns, they say that more holistic approach can decrease that concern significantly. And so then some others, people were saying, some other constraints that were built were constraints about the amount of liver damage that someone has. So some Medicaid programs said, well, okay, we're only going to treat people who have a certain amount of fibrosis, so a certain amount of liver damage. And these programs said, we're only going to treat people who have moderate liver damage or severe liver damage. For those who don't have liver damage, we're going to either hope that they never develop liver damage, or we are going to prioritize those with more severe liver damage now and then treat others later. This study by Bacchus and others provided kind of the impetus to get rid of some of those treatment restrictions based on fibrosis or liver damage, because these authors found that it didn't matter what level of liver damage somebody had, for all people, sustained virologic response or a cure, accessing treatment, was associated with a 67% reduction in risk of death compared to untreated patients. So these authors kind of found that we should, if we want to decrease mortality due to hepatitis C, we should be treating people regardless of their stage of disease. And so those early kind of restrictions on, who could access hepatitis C and how, those still have a legacy today. And so this is it's called the State of Hepatitis C, and it's an organization that ranks states based on how open and how restrictive they are to hepatitis C treatment. And so this organization gave Nebraska a C- rating, between A through F. And the reason they did that was because they found that many of the state Medicaid programs required a fibrosis score of 2 or more. And so that means like moderate liver damage. So you could only access treatment if you had moderate liver damage, or severe. In one case, it was F3 or greater, which is considered severe liver damage. And there was also an abstinence restriction. And so all fee-for-service and managed care organizations that are run through the state's Medicaid program require 6 months of abstinence or evidence of participation in the treatment program in order to access hepatitis C treatment. And so, there's many reasons why states did this, some economic, some medical, some other reasons. And there's a great debate kind of within public health about, are these justifiable restrictions? And so then there are some authors kind of moving towards, if we were to treat hepatitis C super aggressively, we might be able to eliminate hepatitis C, completely kind of get rid of it from the United States. And there are several reasons why we could do this. We have a treatment that works in over 90% of cases. We know that there are very effective ways to prevent transmission, mostly related to syringe exchange programs and syringe service programs. And there's an economic reason. So some authors have pointed out that it would be highly cost effective, especially in the long term. It could lead to an estimated of 6.5 billion savings in US expenditures if we were to eliminate hepatitis C, as well as some other intangible benefits like quality of life improvements and productivity improvements. And these authors, who are kind of very well known, it seems, in the hepatitis C research and medical community, cite that probably the biggest barrier to eliminating hepatitis C has to do with politics. There's not really a huge awareness that hepatitis C is a massive problem, or a commitment to eradicate it, or eliminate it. Eradicate would be get rid of it entirely, but we could eliminate it from the United States, probably, if there was the political will. And so that kind of brings us to, well, if it's possible, what can we do? What can we do to help? So since we're kind of in a more rural state, I thought, well, let's look at what some problems other rural states are facing. So this was a research paper that focused on Wisconsin back in 2012. And so this was right when those direct-acting antivirals were hitting the market. So they were very new then, but these authors found that in 2012, 5,000 Wisconsinites with HCV lived in a county where there was no health provider who had prescribed treatment for HCV. And 51 out of the 72 Wisconsin counties had no providers who had provided HCV treatment in 2012. And so these authors were saying there's a really huge need to ramp up treatment of hepatitis C in rural areas, because there are whole populations that we cannot reach because there are not hepatitis C practitioners there. And so how do you go about, bringing providers to rural regions? It's a huge problem throughout many conditions. The University of, I believe it was New Mexico, they have this model, the ECHO model. And this is it's merging things like telehealth and linking specialists with people who work in those rural regions. And it's a model that you can okay, maybe we can't have a specialist in each county, but we can make sure that every provider is linked to a specialist so they can still treat people who present with hepatitis C. And so that's a model that seems like really good success throughout the world. They started locally, and this model has been exported all over. And so that's one way, merging telehealth and some other models to maybe increase access to treatment. This is another graphic that was put together with the help of Bergen. And it's so the text from this comes from the Center for Disease Control. And they outlined a bunch of ways that we can achieve HCV elimination, or at least reach our targets for HCV reduction. And they were talking about the need to improve linkage to care. When somebody presents with a need, there needs to be a provider that is accessible. Community level programming. So that means that we need people who are in the community who can advocate and link people to treatment and talk about these issues. Testing and treatment. There needs to be this people who need the cure or who present should have access to that. Funding and data collection. Seems like with hepatitis C, there's not as much, it's hard to come up with trends because there is such that under testing, and we don't really have these as great of a prevalence numbers as we would like. So that's definitely something that we can improve. And then researching prevention methods. So what are new ways, what is the effectiveness of the ways that we have to reduce the impact of hepatitis C on our communities?